Yes, sir.
Yeah, fine. So, good evening, all. It's a last talk of the day, and I'm sure you must be tired and it's pretty long talks. So, I'll try to finish, simplify as well as finish in time so that you understand it well. So, the topic is renal issue. Whenever we come across with any patient who is critically ill, irrespective of ECMO or any other ICU patient, development of acute kidney injury is pretty common in the intensive care patient. And similarly, in the ECMO patients as well, the acute kidney injury is quite common, especially in the VA ECMO. However, incidence is quite high in the VV ECMO as well. And once the patient develops acute kidney injury, the outcome is always poor. We know that once the patient gets suicide, the mortality increases by almost 10%. And usually it is not only the acute kidney injury, but it's the fluid overload also, which is very common in these patients because we give a lot of fluid during their resuscitation, during the shock management. So if you look at the different age group prevalence, as per the ELSO registry, almost 25% in the neonates, while in the pediatric population and adult population, it goes as high as 85% The problem is most of these studies are of single multiple definitions of acute kidney injury, and that is probably one of the biggest drawback of all these studies. And it's only a ELSO database, otherwise we don't have much of the criteria. So we follow several criteria for identifying for acute kidney injury. And one of the common criteria what we use is the Raffles criteria. The first three, risk, injury, and failure, actually talks about considers the acute kidney injury, where they take the creatinine and the urine output as the criteria that worsening of creatinine or drop in the urine output in the different time figure of 6 hour, 12 hours, or 24 hour, or anuric patient for 12 hours at the failure. The last two are basically for the chronic kidney disease. Other criteria stage 1, 2, or 3 is more than two to three-fold as a stage 2. And similarly, the Akin criteria also looks urine output and creatinine in the consideration. So more or less, both the studies, if you look at the studies, both the criteria work very well, and the incidence roughly remains the same if we follow any of these criteria. So why these patients are at more risk? The most important is the patient's pre-treatment factor, because these patients when they are on the inotropic supports and vasopressor supports, they are in the low cardiac output state. Those patients who have been chosen for the VECMO are a patient of chosen for VV ECMO or hypoxic, and this all leads to a systemic inflammatory response and the loss of autoregulation. Moreover, the various drugs administered during the course of illness, a lot of drugs are nephrotoxic, and we keep pushing the fluid to manage the shock, and these patients ultimately land up with a fluid overload. Besides this, there are several ECMO variables which also going to affect the acute kidney injury, worsen the kidney injury, or they can lead to acute kidney injury. Because when we talk about the VA ECMO non-pulsatile flow, this compromise the renal perfusion, and we try to suddenly reduce the vasoactive drugs. That again contributes a sudden drop in the hemodynamics, and that also alters the renal perfusion and drop in the urine output and lead to acute kidney injury. Moreover, the dysregulation of renin-angiotensin system or the ANP downregulation. Systemic inflammatory response because of the uh, circuit, these foreign material of the circuit blood-air interface, this all lead to shear stress. Moreover, organ crosstalk and circuit-related factor which leads to a hemolysis or hypermyoglobin. So, as the higher the rifle classification, the stage increases, the mortality also increases, ranging from 20% to almost 30% when we reach to a stage 3 of the Rifles criteria. Moreover, the risk factors, which where the AKI during ECMO may be developed, older age group, patients with the comorbidities, patients is the post-cardiac shock, or we delayed the initiation of ECMO, or patients with LV dysfunction, patient required the blood transfusion, or lactate levels are very high, and there's increased bilirubin or plasma-free hemoglobin. So a survey was performed almost 10 years back to see the practices of the renal support during the ECMO, and what they found that there is a lot of discrepancy. Um, 25% centers are not using any renal support therapy. However, predominantly they were using a convection and included slow content ultrafiltration, and the most common indication was prevention of fluid overload and the prevention of fluid overload. So almost fluid overload is one of the commonest indication. Besides this, prevention of fluid overload, acute kidney injury, uremic symptoms, and electrolyte disturbances. These are the common indication of ECMO to CRRT. Use of the renal replacement therapy. So what are the benefits of combining when a patient is on ECMO by doing any renal replacement therapy, and especially when we talked about the continuous renal replacement therapy, we manage the severe lactic acidosis, we avoid fluid overloading and the hypocalcemia, we establish favorable volume status that improves the lung functions. We can use the nutrition, we can administer the medication liberally, blood and blood product liberally, and there is no electrolyte imbalances which can further worsen the patient condition. So there was a retrospective analysis where they show that early fluid overload before continuous ultrafiltration and survival in the pediatric population. We showed a survivor had the less fluid overload as compared to the non-survivor. And we know that for any ICU patient, if the fluid overload is less than 10%, the survival rate is very high. If the fluid overload is more than 10%, even after the initiation of CRRT or any renal replacement therapy, the chances of survival are much, much lower. So when to start? The actual time is actually it is not yet well defined, but yes, we believe that the early CRRT may be beneficial, especially when we are trying to manage the fluid or we are trying to correct the metabolic components. And delayed is the start of renal replacement therapy is always associated with a high mortality. What options we have to do the renal replacement therapy? It can be continuous. By definition, the continuous means when the renal replacement therapy is going beyond 24 hours. So it can be a CRRT, means extracorporeal circuits, and there can be peritoneal dialysis, which can also go beyond 24 hours. Moreover, we can do intermittent hemodialysis, usually not a preferred one during the ECMO. Blood sled can be used judiciously because this leads to a lesser hemodynamic stability. So if we compare all the modalities, intermittent hemodialysis definitely is the cheaper, reduced downtime, lower cost. Um, it can be connected to the circuit, but the issue is there is a lot of hemodynamic variation. There can be risk of cerebral edema, disequilibrium syndrome, and it's more complex. So if we convert it to the prolonged IHD, that what we call it as SLED, then definitely it removes the volume slowly, so more nicely tolerated by the patient, less costly as compared to the CRRT, but yes, there is still risk of hypotension. CRRT, which can easily connect it with the main ECMO circuit and it can go continuously for 72 hours or more than that, it allows us to have a tight fluid balances. We remove the volume gently, so less minimum chance of disequilibrium syndrome. And in fact, it takes out some systemic inflammatory markers, which helps us to stabilize the hemodynamics. But definitely, it is a costly. There is a risk of hypothermia and immobilization, which is a common complication of CRRT. But during ECMO, probably these two can be taken care of because the patient is already immobilized, and the hypothermia is not an issue during an ECMO. Peritoneal dialysis usually restricted for the pediatric population, usually not done in adult population, but yes, can be done if there is no abdominal issues. So the various modes what we use during the renal replacement therapy, it can be scuff, slow continuous ultrafiltration, CVVH, continuous veno-venous hemofiltration, CVVHD, continuous veno-venous hemodialysis, and CVVHDF means combination of those two, hemodiafiltration. So SCUF, it is just a slow continuous fluid removal. There is no solute clearance. Only we maintain a blood flow and we take out the fluid from the body. CVVH, which is a main principle, is the convective clearance through which there is a solvent drag and we can remove the middle molecules with use of the CVVH, where we are using a replacement fluid. Whatever amount of fluid is coming, we are replacing it. CVVHD, it is the diffusive principle is the diffusion. That is the normal routine principle of the any of the dialytic modalities, where we are using a dialysate which is moving the countercurrent direction of the blood flow, and we are taking out the small molecule in the form of urea, creatinine, or other smaller molecule. A combination of diffusive therapy and convective therapy is the CVVHDF, where we connect both dialysate and replacement solution, and we can take the fluid whatever amount we want to remove depending upon the patient condition, and this helps remove both middle and small molecule. So how to do during an ECMO run? It can be performed through a separate venous access. So there will not be any integration of the two modalities of the extracorporeal therapies. We can use inline hemofilter, which is conventionally done in the operation theater during the cardiopulmonary bypass, but that can be replicated along with the ECMO circuit itself and can be performed in ICU. And third, we are integrating the CRT machine with the ECMO circuit, means we need to integrate both the extracorporeal therapies together. So independent, there is no issue. Advantages, there is no interference with both the system related with the hemodynamic of the therapies. You just place a dialysis cannula separately and you initiate CRT separately. But the disadvantages, because patient is on heparin, so more risk of bleeding, and you are losing one venous access because which may be required during an ECMO run for the access if the less flow is there in the ECMO and you want to put another cannula. Otherwise, it's separate, probably it's a good one. Inline filter during the ECMO, it is cost effective because you are just putting a filter. Usually with the filter only you can take out the fluid. But when you add dialysate to it, you can convert the therapy with the as a CVVHD, and when you add the replacement fluid, you convert the therapy to the CVVHDF. But only issue is these replacement and dialysate fluid has to be administered with the use of um, infusion pump, which can be an issue because their accuracy definitely is going to be compromised. The third method is you are integrating both the system. You can see this is our ECMO circuit and you are integrating the CRT device with the ECMO circuit itself. And there you can take the blood from the ECMO circuit itself, and after purification of the blood, it can be returned back to the ECMO circuit itself, and the purified blood will go to the patient. So the advantage, we can easily set up this circuit. We are using a low flow blood volume, hardly 100 ml or 120 ml or 150 ml, and easy to operate. Once you have attached it, you don't need to replace, you don't need to touch the circuit regularly, and oxygenator is going to help to have any air bubble which will be trapped there, or any small air bubble or a clot. But the problem is there will be interference in the blood flow of the CRT as well as the ECMO circuit. So because they have the different pressures, so what problem can happen? One can affect the other one, or if there is a issues with the CRT circuit, some air comes in the circuit, that will definitely compromise the ECMO, especially in cases of VV ECMO, where the patient is totally dependent on ECMO for oxygenation. So even the 100 or 120 ml of blood taken from the ECMO circuit for the purification probably can reduce the oxygenation. You need to adjust the blood flow. So we can see this, one of the combination of the circuit, there can be different places where you can connect your circuit. So you can see here, this is the drainage limb of the patient, this is the pump, this is the oxygenator, and you is going back. So this is one, if you're using a roller pump, then possibly it should all be the pre-pump. But if you are using a centrifugal pump, which we commonly use for the ECMO itself, then multiple combinations pre-oxygenator, and the return line can be connected before the pump itself. So this has the high pressure line, new pressure, and you are returning back here, so less risk of any air embolism, and because you are correcting it before it, so there is usually hemodynamic variation will not be there, and moreover, if there is any clot, it can be trapped with the oxygenator. The only disadvantage of this method is there can be recirculation of the dialyzed or this blood. So there will be some recirculation, and quality of dialysis or purification will be bit compromised. Another combination, you can just connect the access line and return line both between the pump and oxygenator. Again, because it's a high zone, rest all otherwise the quality of dialysis will be good, and usually there is no risk of air entering in the centrifugal pump and nothing can go to the beyond the oxygenator. One thing you should remember, anything you are connecting beyond the oxygenator, if there is a bubble or there is a small clot, it can directly go to the patient. Another combination, not a very common combination or not a very accepted one, that you return line, access line you are placing after the oxygenator, and drainage line, return line you are connecting before the centrifugal pump. So how this is helpful? Again, this is the pressure, positive pressure line, and there is a more risk of bleeding if there is some disconnection. So blood loss can be there, and any clot or air bubble on this zone, it will directly go to the patient. You cannot stop it without stopping the ECMO itself. But the advantage is there is a constant or optimal inflow to the CRT circuit because it's a high pressure zone, and no resistance in the outflow from CRRT, means return line of the CRRT. Nowadays, all these oxygenators are provided with the port on the pre-oxygenator and post-oxygenator area. So here, these circuit can be nicely connected with this. These are the most useful combination where you are the post-oxygenator zone, you connect the access line, and pre-oxygenator zone, you are connecting the return line. So any air bubble or clot will be trapped in the oxygenator itself. The only problem is because of these pressure differences, if the quality of the oxygenator may be compromised, and your oxygenator may get clogged early and need a replacement because it's a costly oxygenator. So you have to be careful. Otherwise, this is a good combination to the CRRT or dialysis, any dialytic therapy using this combination. The other combinations, not a very common one, you can have access at the pre-pump area and return line between the pump and oxygenator. Here, there is a more risk of the air sucking in this because it's a negative pressure zone and there's a small leak, so air will coming in the circuit and it will keep giving an alarm. But you should be very cautious about the alarms to I told while I'm again sharing the screen. I think it got disconnected because of some technical glitch. My screen is visible now. Okay. So metabolic control usually not if you are using it for the scuff, but in CRT machine it is possible. ECMO flow, again, we are shunting the blood, so it will lead to a drop in the oxygen, while there is no change in the during the CRT machine. So, but you should remember careful about the complication of the dialysis, because these are associated with the various modalities, whether we are choosing a CVVS, CVSD, or CVVHDF. So, one, we are taking too much of fluid, so it can lead to hypovolemia and hypotension. If we are using a dialytic as well as the convective therapies, there's a more risk of electrolyte imbalances. There can be risk of poor flow, bleeding, or thrombosis. Machine related issue, it can add on to the hemolysis, because both extracorporeal therapies were integrated together. More if there is a air, there is a risk of air imbalance. Renal recovery, usually the data is so far is very limited who have received the combined ECMO and CRRT, but yes, available evidences favors the renal recovery outcome among the survivor when it is performed early in these patients. Early renal placement therapy in these patients, especially for the fluid removal, has shown a survival benefit. This is the paper in the 2015. They concluded the RRT mortality rates in the patient receiving ECMO are high regardless of the age or indication for ECMO itself. However, the higher the mortality in the control population, the more mortality decreases overall, suggesting that this is more likely caused by the disease severity rather than number was very small, but this shows that probably an early CRRT may reduce the uh, chances of death during the ECMO run. So, to conclude, patients who are receiving ECMO, whether VA or VV, are at a high risk of developing fluid overload and acute kidney injury, more chances in the VA ECMO. Cumulative fluid overload is associated with the high mortality, prolonged ICU stay, and duration of mechanical ventilation. Pathophysiology is associated with the related with the renal oxygen delivery or inflammatory damage, and more likely it's a pre-ECMO factor itself, and ECMO itself can contribute to the acute kidney injury. And almost 50% patients who developed AKI, they need